Good evening, distinguished guests and colleagues. I'm Khairiyah Kassim, lead psychologist and head of operations and resilience psychology branch from the Singapore Civil Defence Force. Today, I am honored to share with you insights into operational stress and trauma for our emergency responders. This presentation aims to provide a dual perspective of how operational stress can manifest and still be managed adequately from the perspectives of a clinical practitioner and survivors of acute stress using case studies. Emergency responders are faced with challenging and potentially draining situations in the course of their duties. Rendering emergency support to the survivors and victims, while necessary, can put them at an increased risk of trauma. Emergency responders may experience a myriad of symptoms associated with acute trauma stress reactions due to the nature of their work, such as intrusion, avoidance, hyperarousal, and mood fluctuations. Individuals can experience cognitive and emotional reactions, which can also contribute to strained family relations. It can also increase the risk of development of more severe forms of psychological disorders and prolonged acute trauma stress reactions, which could also lead to a diagnosis of PTSD. Due to a heightened level of psychological symptoms, the morale of teams can be affected. For example, social withdrawal that are possibly experienced by affected personnel can result in reduced communication, increased potential conflicts, and overall reduction in team morale and operational readiness. The exposure of critical incident stress doesn't just affect the individual. At an organizational level, it affects overall morale, job satisfaction, and turnover rates. That is why the management of frontline job stress, especially for those who are, especially those who are more exposed to unprecedented calls and ops, is crucial in our work. The frontline job our colleagues are involved in has its risk. A Bolt and colleagues study in 2015 estimated that 30% of emergency responders develop behavioral health illnesses, including but not limited to depression and post-traumatic stress disorder, as compared to 20% in the general population. In another study by Lewis and colleagues, found that ambulance personnel develop PTSD at rates ranging from 9 to 20%, 22%, and firefighters at rates from 17 to 32%. This contrasts with approximately 7 to 12% of adults in the United States that will develop PTSD at some point in their lifetimes. So how does this look like on the ground? A personnel is trained to look out for signs and symptoms of stress. However, when an unprecedented chain of events occur in the line of duty, a critical incident may occur and the officer experiences extreme stress which overwhelms his or her coping strategies. This operational stress therefore invites an experience of acute stress as he or she responds to a traumatic event. Over the course of a month since the onset, the individual then experiences symptoms of intrusion, avoidance, hyperarousal, and mood changes. And when these symptoms remain unaddressed sufficiently, the experience prolongs and could lead to a diagnosis of PTSD. So what then do we look out for in minimizing the psychological and behavioral responses and trajectory of distress? The clinical definition of peritraumatic distress is a subjective sense of numbing, depersonalization, detachment or absence of emotional responsiveness, and an alteration of awareness of one's surroundings. Such peritraumatic distress reactions are taken into consideration in predicting adverse mental health outcomes following trauma exposure. And if the operational stress and peritraumatic distress is not addressed sufficiently, emergency responders may find themselves struggling with mental health issues. This could involve distress responses such as irregulated sleep, distraction, isolation, and decreased sense of safety. Over time, officers may experience psychiatric disorders and possibly engage in health risk behaviors that may affect their overall well-being. Presence of PTSD in emergency responders itself has been found to be related to reduced quality of life, poor physical health, more medical visits, and more suicidal ideation. Thus, early interventions are vital, as adverse mental health outcomes may contribute to adjustment problems in social, family, and work setting. SCDF employs a holistic approach in managing the operational stress of personnel. Psychological resilience training and support is provided at pre-deployment stage. During deployment and operations, we continue to provide psychological support for major operations and exercises. Group and individual follow-up are also provided for those who may be affected due to the exposure of critical incident stress. Not just that, SCDF provides a 24/7 counseling helpline, and we built our network of SCDF prayer counselors made up of regular officers and national servicemen full-time support network. In-house psychologists therefore play a vital role in the management of acute stress among frontliners. It is within our expertise to differentiate the nuances in the psychological and behavioral presentation through clinical judgment, and then propose and effectively implement relevant interventions to enhance recovery and post-traumatic growth for these individuals, minimizing undesirable mental health disorders. Let me share with you about Matt and Darren. They are our in-service officers who have provided their consent to share about their stories and experiences with operational stress. Their names have been changed for the purpose of this sharing. First, Matt was my client in 2021. He is unmarried and had no romantic partner. He had an uneventful history and did not present with any significant concerns in his work as paramedic in the past 3 years. He completed all relevant trainings and performed his duties diligently. He signed up for the job as a full-time paramedic to save lives and was aware of the nature of the job. In his 3 years of experience, he had responded to various types of calls, including deaths of his patients on arrival and patients who had also succumbed on their injuries subsequently. 2 weeks prior to our meeting, Matt attended to a call to respond involving a toddler. Toddler was assessed to be responsive upon his arrival. The ambulance reached the accident and emergency department, and Matt handed the patient over to the hospital staff. He walked away briefly and then came back to hand over the necessary documentation. But just as he opened the curtains, one of the staff stared at him hard. The staff was resuscitating the child. Matt handed over the file, left the scene, and started pacing up and down near the ambulance. His colleagues asked what happened. He started talking fast with his hands shaking. The scene was shocking for him, out of his expectations, but this was not mainly because a child was involved. The distressing scene for him was a stare of the other individual, and in Matt's perception, it felt as though he was blamed for the child who went unconscious in his absence. So Matt persevered after the call. He went on to his own routines, but he knew something was wrong. Shortly after the incident, he started experiencing flashback, manage the anxieties, and to continue his work as a frontline. So I saw Matt for a couple of sessions. He was a willing party to reduce distress levels through the use of psychological interventions with me. In the first 15 minutes of our sessions, his hands were trembling, his speech rate was rather fast, and I noticed how he tried his best to maintain his composure, but still very much in a hyper-aroused state. The rapport building was necessary for Matt to experience sufficient psychological safety so that he could disclose what had happened without the fear of being judged. We also had relaxation strategies to manage his arousal state first, worked on relaxation strategies such as deep breathing. This was necessary to allow his rational mind to slowly come into the session. Then once he was calmer, he will revisit his traumatic memory, and of course at this time, Matt left out many details of the event. We had to go slow and sequence the chain of events well enough for my own understanding. And using a Likert scale, we identified his most distressing scene, which was about the other party looking at him in the eye. And at this stage, his anxieties heightened, and relaxation strategies had to be practiced again in session. Subsequently, we worked on making sense of the experience, finding evidence to why he could possibly have felt that way, and using evidence to challenge his unhelpful thoughts as well. This was done with caution, and equipped with the necessary skills and knowledge, it was important that Matt felt safe to share his inner thoughts and emotions. There was a lot for Matt to work on between our sessions. At the supervisory level, we also worked on providing the psychoeducation on symptoms and management of operational stress, as well as providing him with the necessary hand-holding and exposing him gradually back into the front line. As a result, Matt's symptoms on the psychological screener, a week apart, indicated a very quick decrease over his depressive, anxiety, and stress symptoms between the 2 brief sessions we had, similar to what I had observed in my session. His motivation to address his issues enabled the session to go smoothly, such that he was willing to consider alternative thoughts that were more helpful for him to believe that he has done his best in the situation he was confronted with. More importantly, Matt, he strengthened his social support by tapping on his colleagues and supervisor. And then there was Darren. Compared to Matt, who had signed up for the job, Darren was a client who was serving his national service. He was in his early 20s. He was serving the nation as part of the 2-year requirement by the Singapore government. As compared to Matt, he did not sign up for the job and did not have any prior experiences. Darren was referred by his supervisor due to his reactions after responding to 2 back-to-back calls. It was his second duty as a frontliner. He and his team were responding to a call as a patient had needed help for a back pain. His patient, however, had collapsed in front of him after suffering from a cardiac arrest. Despite his team's best effort, the patient did not survive. In the second call, immediately after his team reached back to the station, it was another cardiac arrest call they had to attend again. Things were messy, Darren panicked, and he did not know what to do. He had lost focus and ransacked the work item and could not compose himself. This time, the patient survived, but he kept apologizing to his team. So Darren began doubting himself, questioned his competency. He feared for the worst-case scenarios every day before his shift. He became more and more anxious, had difficulty sleeping, and his mood was affected. He could not stop himself from experiencing disturbing thoughts, and his self-confidence went downhill. My experience with Darren was unique. We had 2 sessions over Zoom due to the COVID-19 situation. This was a challenge for me. During our session, Darren appeared slightly worried. His narratives were full of what ifs. What if I'm unable to perform during my next duty? What if I were a burden to my team? I tuned to the frequency of his voice and the subtleness of his anxieties. So to work with Darren, it was important to revisit the events again and identify the common theme and unhelpful thoughts that made him worried for his calls. Suicide risk assessment was also conducted and providing the necessary education on his symptoms when necessary. We focused on equipping him with the necessary skills with involved deep breathing during our session. Similarly, we worked with his supervisor closely. The combination of both individual and operational level interventions helped Darren to continue to cope with the demands of the operations work. In his narratives, Darren also shared the following. If I know a case is quite bad, it's going to be urgent, I'll feel a sense of panic, and that's when I'll start to apply these techniques, which I'm still using up till today. I have a clearer mind, I'm more composed. On the way, I'll do the breathing techniques. Through Darren's case, we learned that these skills are useful when it is incorporated into the work routines. And that we learned that it is not a case where acute stress goes away immediately, but it is more about growing with the stress and handling with the stressors when they come. Through these case studies, we identified that the frontliner's perceptions towards the most distressing moment had contributed to the acute stress, and this was therefore an important element that we worked on during the sessions. What was helpful was indeed their motivation to recover and grow from their experiences, regardless of whether they had signed up as a full-time officer or just serving their national service full-time. In short, the elements of the TFCBT was used to manage the acute stress reactions of Matt and Darren. This is supported by multiple studies in various contexts. For example, Brian and colleagues studied patients diagnosed with acute stress disorders within 2 weeks of onset and found CBT resulted in greater reductions in intrusive, avoidance, and depressive symptoms compared to supportive counseling. While pharmacological interventions can be helpful to minimize the physiological reactions, its effectiveness can be limiting. Hence, in this case, psychotherapy is important and essential for management of acute stress reactions. That is not all. These 2 individuals would not have grown from their experiences if not for the perceived supervisory support and close partnerships within the psychologists and the supervisors. In the Singapore context, and the in-house psychologists can work with supervisors directly to help our frontliners return to normalcy. For practitioners among us, this means that being able to have clients like Matt and Darren go through gradual exposure as supported by the supervisors. We work closely with Matt and Darren supervisors by explaining to them about what gradual exposure is in layman's term, which is to slowly expose and re-expose the client to the nature of the job and work in tandem with them to ensure that the symptoms are managed sufficiently. In our experience, supervisors are willing parties in the equation. Supervisory support is key to one's post-traumatic growth. In summary, the stories of Matt and Darren elaborate on the acute stress reactions that they had experienced in their operational work. There are 2 main levels that we worked on, first at an individual level and second at an operational level as following. While Matt and Darren's cases illustrate the successes of interventions through the individual and supervisory level, this presentation has some limitations that require further considerations. First, casual check-ins with Matt and Darren revealed that they have been coping and is still in the front line. It can nonetheless be helpful for us to continuously track their symptoms through post-intervention follow-ups. Second, perhaps it could be helpful to explore the relationships between the different mental health-related markers and the different types of operational stress. For example, which symptoms are related to the acute stress, and if these symptoms differ from an individual experiencing prolonged exposure to trauma. In future, we could also explore other forms of treatment methods to help our frontliners in individual settings, such as the use of eye movement desensitization and reprocessing techniques, and to compare and contrast with the TF-CBT approach. Moreover, advancing our research to enhance resilience for frontliners can be explored using technologies. Through this presentation, I hope that we have been able to identify the role of practitioners in public service in supporting frontline work, highlight that psychological interventions can have desirable outcomes if conducted at the individual and supervisory levels. Also, I hope this presentation exemplifies the importance of collaboration and strong partnership between affected individuals, supervisors, and practitioners. Finally, the exploration of various modalities and also advancing research can also potentially enhance resilience for our frontliners as we continuously improve on our mental health services and to contribute to the scientific field of emergency responder services. Thank you.